Welcome to this week's edition of Ask an MS Expert. I'm John Strum, and I'm the host of the Real Talk MS podcast. Each week, Real Talk MS reaches thousands of people in more than 90 countries around the world with the news that people affected by MS need to know. I'm also a non-scientist member of the International Progressive MS Alliance Scientific Steering Committee. I'm a district activist leader for the National MS Society, and I chair the Society's California Government Relations Advisory Committee. My wife, Jean, lived with progressive MS for 23 years, so I've had a front row seat experiencing all the ways that MS can impact a family. I'm thrilled to be with you today. I see that people are continuing to join our webcast, so let's give them just another few seconds and then we'll get started. Thank you to all of you who are joining us on GoToWebinar, Facebook Live, and YouTube Live. The MS Society's Ask an MS Expert webcast is designed to connect you with MS experts who are ready to answer your questions on the topics that people affected by MS ask every day. So as I chat with our expert today, please feel free to post your questions on Facebook and YouTube, or type them into the question box if you're joining us on GoToWebinar. We'll try to answer as many of your questions as we can during the Q&A portion of today's program. I'd also like to take a moment to acknowledge and thank today's program sponsors, Bristol Myers Squibb and Janssen Neuroscience. Without the support from our community partners, programs like this just would not be possible. There have been several promising new signs that point to better treatment options for people living with MS. These indicators include a better understanding of the disease, new oral and longer-lasting therapies, and better insight into how to lessen MS damage. Still, managing and coping with MS can present difficult challenges, and disease-modifying therapies can play an important role in a patient's MS journey. Today, we're talking with Dr. David Matson, a professor of neurology and director of the Neuroimmunology Multiple Sclerosis Program at the Indiana University School of Medicine. In addition to diagnosing and treating patients with MS, Dr. Matson has a PhD in immunology and conducts clinical trials of new treatments for multiple sclerosis. Welcome, Dr. Matson.
Thank you. I'm excited to be here today. Thank you.
I've often heard experts say that disease-modifying therapies are the cornerstone of treating and managing multiple sclerosis. I'm hoping you'll get us started by explaining why that is. What do disease-modifying therapies do for people living with MS?
I mean, disease-modifying therapies are really a big step towards trying to reduce damage, reduce disability. Important to realize that none of the drugs we have yet are the cure, but we're making more and more progress. So these drugs are all proven to, at some degree, reduce attacks, reduce disease progression, which is progressive accumulation of disability, decrease new MRI lesions, which again then translates into new attacks or new disability when they occur. And then ultimately, any new attack or progression runs the risk of leaving behind symptoms that a person has to deal with. So ultimately, all these things are proven, these immunotherapies, to slow down the disease activity.
I've come across lots of posts on social media from people who assumed that disease-modifying therapies would just make their symptoms go away. And when that doesn't happen, they get frustrated, they get discouraged, and some of them even give up. So can you clear up this confusion and explain how disease-modifying therapies work and what they actually accomplish?
So what they've all been proven at some level to do is to decrease the inflammation in the brain that causes new lesions, causes new damage, and any new attack can leave behind symptoms. The goal is to reduce the number of attacks, reduce the severity of attacks, make the recovery from any given attack better, because once a symptom is there, once a lesion is set in, it's a much harder thing to then play catch up and get rid of it. You're much better off preventing a problem before it occurs. And ultimately, I mean, I think what we hope is to be able to minimize new symptoms or minimize the symptoms that have occurred and stuck, and then we can work on treating those symptoms. But just the fact that there are symptoms occurring on disease-modifying therapies doesn't mean they're not working. Obviously, we'd like to minimize the number of new symptoms that occur, though.
We've heard from Rachel, who tells us that she's 30 years old, and she was diagnosed with MS just 2 months ago. Rachel can't decide if she should start on a disease-modifying therapy and wants to understand whether there are benefits to starting sooner rather than later. So when should people consider starting a disease-modifying therapy?
I mean, I think more and more we are about trying to treat as early as possible. Once we have a definite diagnosis, or even sometimes when we have a probable diagnosis of somebody that's got a first exacerbation with other signs on spinal fluid or MRI that show an indication that this is in fact MS, we want to be proactive and treat at that point and not wait for more damage to occur. I mean, time is brain, and the longer you wait, the more chance there is to be another attack or to be disease progression that will leave behind symptoms. And often people feel good even after their first attack and they've recovered from it. But what they need to realize is that MS can be a very sneaky disease, and things can be going on the MRI scan that they're not even aware of or don't feel as an attack. And we as neurologists may not even see as a change on their exam. But ultimately, those lesions or those silent activity will translate into eventually new disability, new symptoms. So ultimately, we're better off treating early. And the other thing about that is that we realize that over time, the immune response, which is causing the damage, gets messier. And so if we can nail things early and prevent the immune response or the abnormality of the immune response from getting messier, we can then prevent further damage.
I think you just about answered the question I'm about to ask you, but I think it's worth asking because it's a slightly different side to this same riddle that some patients face. We get this question frequently. What about someone who has no evident impairment, mild disease activity? Do they need to be on a disease-modifying therapy? So we know we should start early. Who should consider starting a disease-modifying therapy?
I mean, on average, all people diagnosed with MS should be on a therapy. I mean, I think that there's always this talk about benign MS, and of course, we all want everybody to be a benign MS. We want to make it benign with our drugs as best we can, even though, again, none of these drugs are quite that cure. The problem in MS is we don't have good crystal balls. We don't have good ways of predicting the future. And so ultimately, even though someone feels good and looks good at a given time point, you just don't know what the future is going to hold. And until we get better markers for the idea that perhaps there are a subset of people that might be able to get away without therapy, on average, we recommend people be on a therapy.
Well, the flip side of the question I just asked you, I think, comes from Alan, who says he's 63 years old, and he's thinking of stopping his disease-modifying therapy, but Alan's still wondering whether that's a good idea. Is there ever a time when people should consider stopping their DMT?
I mean, again, on average, the answer is no. I mean, I think if you're feeling good and you're doing great on a therapy and your MS feels like there's not much going on or anything, that's a sign that the therapy is working. And so I think there's no reason at that point to stop. If you're being tortured by your therapy with side effects, well, of course, then that may be a sign you need to make a change, but not to stop completely. There is a study ongoing that I'm not aware is done yet, looking at people who've been stable for several years on an injectable therapy. This was started a while back, who've been stable, meaning no attacks, no disease progression, and no new MRI activity. And those people are being randomized to either stay on the drug or go off the drug to see who gets away with it and who doesn't. I'm not aware of the data yet. We've all had people who've done this on their own or for whatever reason who've gotten away with it, or others who've not. But there's really no scientific way in a study like that, without doing it in a scientific way, to use that information to really predict who might be able to get away and who might not be able to. And I think on average, again, the right answer is to stay on the therapy, or to find a therapy that you can tolerate if the reason you're thinking about going off is because of side effects.
You know, with so many disease-modifying options available now, one of the most daunting aspects of someone's MS journey can be making a therapy decision. Even as we're in the midst of this global pandemic, we've seen the FDA approve new disease-modifying therapies. So how many treatment options are there now for people living with MS to actually consider?
I mean, I think I've almost lost count myself, and I think we're up to like 15 or 16. Some of that counts new drugs that are like another variation of the same thing, brand versus generic, so they're not truly a new drug, but there still are literally 15 or 16 choices at this point. There's the old injectables, that's been our first generation, then there's been pills, and then there's a variety of infusions with different cycles or frequencies of infusions.
Besides differences in the method of delivery, oral versus injection, for instance, aside from those differences, and aside from the generic versus brand differences, are there differences in how some of these treatments actually work?
There are, and that has been relevant over the years, but also more relevant even now in the middle of this COVID-19 pandemic. I mean, some of the original injectable drugs are what we call immunomodulatory. They change the immune system in a good way. They don't suppress the immune system. In general, since the injectables, the newer generations of drugs, the pills and most of the infusions, to a various extent, and none of them are dramatically immunosuppressive, but they do suppress the immune system to a certain extent. And they can do that in a variety of ways as well. Some of them will just blunt the activity of the immune cells that are overactive. Some will literally ablate and wipe out that cell population that's overactive. Some will sequester the abnormal cells in the lymph nodes where they can't do damage. And then others will coat the cells so they again can't do damage. So there's a variety of ways that they do it, but all of the theme would be on those different infusions or pills, ways of either blunting or suppressing the immune system.
We've heard from Tanya, who said that when she was diagnosed, her physician sent her home with 3 or 4 drug company pamphlets to review, with instructions to call the office back and let them know which therapy she preferred. And Jeff wrote that he wasn't aware that he had any options when he was diagnosed. His physician didn't have much time to discuss treatment options and just prescribed him a specific therapy. And it seems as though these approaches represent 2 ends of a spectrum, neither of which is ideal. Dr. Matson, could you walk us through the process you use to help your patients select the disease-modifying therapy that is best for them?
So I agree. I mean, those 2 extremes, I think, are not ideal in either case. And I do think ultimately you want to have a shared decision-making. You want to have buy-in. It doesn't matter what I think is best, what I think appeals to me the most, because ultimately it's the patient that's got to start and stay with whatever the therapy is. So ultimately, if they don't buy in, or if there's a problem right up front, well, they're not going to stick with the drug. And at some level, what matters really is the long haul, something you can stay on, assuming it's effective and doesn't have side effects, to the extent that you can then stick with it. So to me, I guess I feel like, as part of that shared decision making, there's got to be time. And unfortunately, well, I guess it's just the fact of the matter that it takes time to take care of people with MS, and you need to give that time. And sometimes it's myself, and sometimes it's a nurse, or if we're online, because a lot of times we have internet within our healthcare electronic record, where I might, if we're going to be starting or thinking about changing therapy, suggest to the person that they might look at least online at a couple of possibilities to focus our discussion the next time we see them. But I guess my feeling up front, though, that you need to get a bit of a feel for, whether they're absolutely opposed to shots, for example, in which case we don't mention much of that, or certain aspects of immunosuppression that would be of concern based on their occupation, whatever, or pregnancy issues. But ultimately, I feel like my job is at least to narrow it down a little bit and maybe at least get to a point where you say, well, if we wanted to go with one of the old 20-year-old drugs that have been around for a long time or tried and true, we know them backwards and forwards, then maybe we can look at an injectable depending on the situation, which I guess we're going to come to in a bit. Or if there's a more aggressive situation, or again, I might steer them a bit stronger. But again, the key point being that you're trying to find something as opposed to nothing, and all of them are on average going to be a better choice than nothing. And the idea is to find the right combination for that given person. But I feel like I like to narrow it down to maybe at least mentioning at least one injectable that they might want to look into in more detail, pick a pill and then at least mention infusions potentially. Sometimes infusions are not necessarily appropriate depending on where they're at with their life and their MS.
Speaking of where they're at with their life, should an individual's health goals, their values, their preferences, and their risk tolerance, should those kinds of things also be considered in this decision making?
I mean, the answer is generically yes, because again, we got to get buy-in from them, and so that's a key point. I mean, I think the goal for everybody, of course, is to be able to get this MS on the back burner as far as possible, and leave it there, and then do what you have to do, and then get on with life. But I think, you're right. I mean, depending on, risk tolerance is an issue. I mean, it's easy to not want to be very risk accepting when you're feeling great. But on the other hand, if you've had a scary onset to your MS, or if your neurologist feels like, based on MRI or them, the onset is a more aggressive situation, well, then I think, it is appropriate to maybe accept more risk. But I think part of that's part of the balance as well, for the patient to be aware that, maybe the milder treatment is got less risk, but less chance of getting ahead of things. A more strong treatment might be, again, better at getting ahead of aggressive situation, but comes with more potential trade-offs of side effects.
Do demographic factors like race or sex factor into the decision to choose one disease-modifying therapy instead of another?
They certainly can. I mean, there's been at least some evidence that African Americans with MS have a more difficult, a more aggressive course, and so we might tend, on average, depending on other factors, be a bit more aggressive in that regard. Women with MS, and again, young women is the typical stereotype of MS, and that's the most common population that has MS. Also is dealing with family planning issues, pregnancy issues, that kind of thing. And again, some of the drugs are better or worse regards to pregnancy decisions. So those are a couple in particular, I think, that do make a difference. In occupations, I mean, certain occupations where there's if there's immunosuppressive aspect to a treatment, might be not as good for certain people that are more exposed to infections.
Thinking back to the scenario that Jeff shared with us, where he was simply prescribed a specific therapy, I'm wondering, what can patients do to ensure their voice is heard and they are a full partner in this shared decision-making process?
I mean, I guess if you've gotten that approach from your neurologist and you're not comfortable, if you're comfortable with it, I guess it can work. If you do that and it goes well and happily ever after. But if it's not feeling comfortable to you or not so sure, you should get another opinion. And I think if any physician does not resent you for getting a second opinion, I think that's a red flag right there. You should always be willing to give a patient a second opinion and find someplace else. And I mean, and again, I think ultimately MS centers do tend to have more time to take with patients. They have the resources. They have a nurse that might be able to be in the loop, or again, maybe online internet kind of stuff that we would do. So I think that those are factors I think that would make it find the right fit. Find the right fit.
Well, thank you, Dr. Matson, for bringing us up to date on disease-modifying therapies and sharing some of the things that people should keep in mind when they're discussing a treatment plan with their doctor. I want to take just a moment to welcome those of you who have continued to join us on GoToWebinar, Facebook Live, and YouTube Live. Please let us know what's on your mind. Post your comments and questions on Facebook and YouTube, or type them into the question box if you joined us on GoToWebinar. Our Ask an MS Expert live event takes place at this same time every Friday. So please help us make sure that everyone knows about it by sharing news about the program with your friends and your family. We're talking with Dr. David Matson about MS disease-modifying therapies and some of the things you might want to consider in making treatment decisions. There's more and more evidence to suggest that lifestyle factors may influence disease course and the quality of life for people living with MS. So I'd like to talk for a moment about lifestyle modifications that people living with MS might want to consider. We've heard from Jason, who says he's 41 years old. He was diagnosed with MS 3 years ago. Now, Jason has smoked since he was in college, but he's heard that it's bad for his MS, and he's been trying to quit. Jason is asking, how badly does smoking really affect MS? So
badly. Yeah, smoking is obviously bad for your general health, and so for anybody, it should be a reason to quit. And if it impacts on the MS, one more reason to try and quit. Smoking doesn't cause MS, but it certainly can increase MS symptoms in the short term while you're actually smoking. There's some evidence of that. But in addition, smoking increases brain damage. I mean, what smoking does is basically causes, I guess, the old generic hardening of the arteries. And you can look at a 50 or 60-year-old smoker, and you see little spots and dots in the brain that don't look exactly like MS, but yet another source of brain damage that adds to the brain damage of MS. And so I think ultimately, smoking is just one other comorbidity that's going to affect your health, in many ways more dramatically and quickly and severely than the MS might. So it just adds one extra source of brain damage.
Can you share any tips that might help someone like Jason quit?
I mean, I think, you know, again, for me personally, I feel like you need to work with your primary care provider, and this is where the healthcare team comes in as to what the best way for a given person to quit is. And I think there's any number of ways that can work. And maybe just the concept, and I guess for me, my job, I feel like, is to emphasize the concept that it's bad for your MS in addition to bad for your general health. And if that's one more reason to quit, well, then it'd be nice if that tips the balance for them.
Since the beginning of the COVID-19 pandemic, alcohol sales are way up. So it's probably an appropriate time to ask, what do we know about the effects of alcohol on MS?
I mean, same thing. I mean, alcohol can cause brain damage. And so we got another source of brain damage compounding the MS brain damage. More specifically, I guess, if you're literally talking about alcohol in regards to intoxication or things like that, MS itself can cause lesions in the brain that are the pathways involved with balance, coordination, things like that. And so ultimately alcohol does those same things. And so it probably doesn't take as much alcohol in somebody with MS who already has a tendency for imbalance or clumsiness or ataxia falling, that the alcohol is going to affect them that much more quickly. And so again, another reason to at least certainly be very careful and moderate. The MS drugs also that affect the liver. And so not that means you can't do any alcohol, but moderation, especially in that regard. And for some people, of course, if the monitoring of the blood work on those drugs indicates a liver issue, well, then alcohol would be in some ways contraindicated.
We get a lot of questions about the impact of vitamin D on MS. Dr. Matson, what can you tell us about vitamin D and multiple sclerosis?
I think vitamin D is an important factor in terms of MS. I don't think vitamin D deficiency is not the cause of MS by any means, but there's a lot of data, mostly indirect, that the vitamin D deficiency impacts on MS. People with low vitamin D levels tend to develop MS more frequently. So, for example, we tend to have lower vitamin D levels the further north of the equator we live, because sunshine is how we metabolize vitamin D in the skin. So, further north of the equator, lower vitamin D levels, more MS occurs, and that's typical. And we know that MS does occur further north of the equator. So that's one issue. At the time of a diagnosis of MS, a low vitamin D level can predispose to increased disease activity or progression. It's a prognostic indicator, not a hard indicator, but at least some indirect evidence for disease activity or progression. And so ultimately, and I think there's a lot of, trying to explain this, it seems like vitamin D does impact on the vitamin D deficiency, makes the immune system a bit overactive. I wouldn't call vitamin D an immunosuppressive compound, but just overall affects the way the immune system works in a good regulatory way. And so ultimately a lower level does seem to predispose to this autoimmune reactivity. So we certainly recommend vitamin D supplementation. And the data have been not dramatic in terms of supplementation, but still as a cofactor, along with whatever improved immunotherapy we've already talked about, the various things that people can be on, this would be an important cofactor to do. You can check vitamin D levels. I often just say, just take 2,000 a day or some supplemental amount. We can check levels, and if they're low, maybe be more aggressive up front and then check later. But ultimately, I think either way, I feel like it's an important factor to take vitamin D.
Are there any other vitamins that people should consider discussing with their doctor?
And the only other one that specifically comes to my mind is vitamin B12. It's one of those vitamins that we check the level on when we're making an MS diagnosis, because a low vitamin D level can predispose to optic nerve damage, can predispose to spinal cord damage, both of those things, and can cause generically peripheral neuropathy. So it can generically cause symptoms that feel like an MS situation. So B12 is checked. Usually it's fine, but if it's low, then we would again recommend repletion. And most people can just take a B complex and it's fine, but there are some people who literally have pernicious anemia, meaning that their gut will not absorb vitamin B12, and then they need B12 injections. It also sometimes can be the case that a low vitamin B12 level can contribute to MS fatigue, and so it would be one of those things people can do. Back in the day, many years ago, before we had MS immunotherapies, B12 injections monthly were a sort of treatment for MS that at least seemed to boost people's energy a bit.
Well, exercise and nutrition have both been shown to play a role in managing MS. So when it comes to the impact of diet and exercise on MS disease course, What do people need to know?
So bottom line with diet is that there's no magic diet. There's no proven diet. So a good, healthy, well-balanced diet is important. There's a lot of diets over the years that have been purported, but none proven. Currently, the Wall diet. Dr. Wall is a neurologist in Iowa that has MS and is doing a study actually to try and show her diet may be helpful. It's a paleo diet, basically, and we'll see what the data look like. I think there's been at least some preliminary evidence that might improve energy a bit, but again, any healthy diet is going to do that. But the bottom line, it's hard to do a study of a diet because it's hard to control all the variables. But I think she's made an effort to do it, and that's good because so many of the diets out there just kind of take on a life of their own without any study whatsoever. But at least so far, no diet has been amazing. And so a good, healthy, well-balanced diet is the important thing. In terms of exercise, I mean, the bottom line is if you don't use it, you lose it. And I think you got to, obviously, within the capability of whatever your disability has allowed you to do, you may have to redefine what exercise is for you, and may be different in terms, may not take as much the typical classic aerobic thing or whatever. But ultimately, it's important to stay active, and it doesn't matter what I like to do. It doesn't matter what's a good exercise or whatever for certain things. What matters is what you like to do, and so you'll do it. And ultimately, you got to stick with it and be persistent. And again, the bottom line being, if you don't use it, you lose it. There's some evidence that moderate exercise can actually help MS fatigue. And as long as you're not using up your daily energy to exercise, and you're using it to leverage your exercise, your energy, then that's an important thing.
Well, you've shared lots of helpful information today. What would you say are the top 3 takeaways that our audience should keep in mind?
I mean, I think the first one is to stay engaged with your healthcare. It's your disease. You're not handing it over to your neurologist. You want to be engaged and be proactive and be the coordinator of your disease activity, and find a doctor you can work with, find a team you can work with in that regard. Secondly, on average, I think stay on a therapy. And if it's not one that you're doing well with or not tolerating, well, then find one you can, because on average, that's the second important thing. And then third, what you want, of course, is to have the immunotherapy, keep things relatively stable. And then the third point would be to get on with life, treat the symptoms that are left over, use it or lose it. And then, and again, try and put MS as far on the back burner at that point as you can and get on with life.
Well, thank you, Dr. Matson, for helping us better understand not only the role of disease-modifying therapies, but the lifestyle choices that people living with MS really need to consider in managing not only their MS, but their overall health. Now, I'd like to continue addressing more of the questions that our viewers have for you. We have heard from Kira, who wrote in saying that she's tired of injections, and she's interested in switching to an oral disease-modifying therapy. But Kira's worried it won't be as effective. Now, we know you can't give specific advice to Kira, but what can you tell us about the factors that might prompt you to discuss switching DMTs with a patient?
I mean, so being tired of injections can be a valid reason to make a switch. In other words, that's one factor, and we do have pills. I will just tell her that on average, I mean, the pills, some pills on average are stronger than injections, and some pills are similar to injections. The problem ultimately being we're handicapped by not every drug we have has been compared to every other drug we have in a scientific study. So we kind of have to give it our gut or our instinct. I mean, the injections, obviously, people think about shots being stronger than pills, but in this case, if anything, I would say the pills on average are stronger than shots. Now, shots can work, and if they do and you're tolerating them well, you stay with it. But if again, she's getting tired of injections, there are a lot of options that don't involve injections, and pills are a big one. Obviously, there are infusions which involve a needle, but it could be once a month, could be once every 6 months, could be various frequencies, and so you can get away from the injections. But I think ultimately the theme, as we've talked all day, is being on something. So yes, if you're tired of injections, that may be a reason to switch, not to stop and not be on anything. Again, I think the other piece is, even if a drug is stronger than one drug stronger than another, it may not matter in a given person. If they're a really good responder to the weaker drug, that may still be a perfect drug for them, a perfect treatment for them.
Well, we have a question that isn't specific to disease-modifying therapies, but I think it sort of relates to part of the conversation we were having earlier. Dean wants to know if it's possible for someone with MS to not have any new lesions on their MRI for a few years. And if that is possible, what does that mean?
It is possible. And what it means is whatever they're doing is working. So keep doing what you're doing. And I guess on average, I would predict that that person is going to have been on some immunotherapy, that they're tolerating well enough to stay with it in the way it was prescribed, and that then that will help their MS to be quiescent. But no, it is definitely possible. And I think more and more in drug studies, we're coming to the concept of what's called NEDA, N-E-D-A, no evidence of disease activity. And what that means is that we're holding drugs to a higher and higher standard. And across studies, it's easier to have just kind of a global concept of no attacks, no progression, no new MRI lesions, and just none. I mean, as opposed to definitions of partial effects or whatever. But literally, we look at these drugs and it's a subset of the people that respond, who have a partial response, that are literally having no evidence of disease activity. And there is a subset of people in all the drug studies of all the different new drugs we have, all these 14 or 15 drugs we have, that literally have no new disease activity. And again, it's the assumption if you're on a drug is that that's the drug that's doing it. And I guess if you're not on a treatment at that point, and for whatever reason you've had several years of no new MRI lesions, it is harder to push that person or have ammunition to push that person to go on to something at that point. But again, on average, the people that are not having any new MRI activity are on a drug.
That's a pretty extraordinary endorsement of disease-modifying therapies in general. When you think about it, we know, how do we always define multiple sclerosis? As a progressive disease. So to be able to say that there's this group of people, the subset, that are experiencing no evidence of disease activity, that's quite a remarkable observation to be able to make.
It really is. And again, I think, with the older drugs, I mean, again, 10%, 15%, the newer drugs, 20, 30, 40%. But again, that's still a huge step forward from what we had, 20 years ago. We had nothing, 25 years ago.
Absolutely. Well, while you and I have been engaged in our conversation, Julie Fiel has been in the background fielding additional questions from the people watching. Hi, Julie.
Hi. This is a great discussion. We've had lots of questions come in. And Dr. Matson, I'd like to start with one that's similar to the question you just answered for Dean, with a little different spin on it. So Sandy is listening in, and she too has not had any new lesions on her MRI for some time. She's been stable on a disease-modifying therapy for 12 years, but she has symptoms that are worsening, like weakness and fatigue, that are affecting her abilities and her movement throughout the day. What advice would you give to one of your patients that's having that those worsening symptoms, but no new evidence of disease activity on MRI?
So that's a little trickier though, because if they're feeling weaker, it may or may not show up on exam, and MRIs are not the be-all either. So just because an MRI is stable doesn't mean there can't be progression that's not appreciated at the level of MRI. It could be a lesion in the spinal cord, for example. And when we talk about NEDA, it's usually, at least in the big studies, they don't do MRIs of the brain and spine along the way. So, I mean, it's possible to have new activity that's in other places. So I do think for those people, I mean, some of it is symptom management, no doubt, and some of it could be not actual new weakness, but maybe more spasticity from old weakness and lesions. So you have to treat the symptom as aggressively as you can, but there can still be some leftover progression. I think the leftover progression is still our toughest piece to crack here.
Yeah. Well, speaking of that, that leads us into Carol's question. Carol wrote in, and she actually told us she's a former patient of yours until she had to move, but she's wanting to know what hope there is for reversing disabilities for people who have more progressed MS. What advice do you give to your patients that are in that situation?
So that is our toughest nut to crack at this point. I mean, I think the leftover progressive piece of MS is difficult. I mean, I think, all the drugs we have and have talked about more generically today are really focused on inflammation, on new lesions, and ultimately we can, in many cases, fairly effectively treat that. But the leftover piece, which is the degeneration of nerves or of the damaged nerves already, is a tough piece. And we need neuroprotection. We need something that will help to repair stem cells or things of that sort. And we don't have anything really good or proven yet in that regard. Part of the problem is that if you had something you thought was going to do some remyelination and start to repair, which we've got some things that could do that, or even native stem cells in the brain that might start to do a bit of that if they're not under continuous inflammation. The problem is that there's still inflammation going on, and that can still then damage the newly formed myelin and things. So ultimately, I think we need to be working on both ends of that spectrum. And I think, there are so-called neuroprotective strategies that are trying to get at the idea of supporting and propping up the dying nerves that are left over once the inflammation is gone, or once we've eliminated the inflammation fairly effectively.
Are we close to seeing any of those drugs come to market?
I mean, I think there are some that are in what we call phase 2 trials, which I think still are at a level that requires the next step. I mean, I think even in some of the relatively smaller stem cell protocols, there is at least some evidence for improvement. Some of the more aggressive immunotherapies, a subset of people that might improve. The question then becomes, who do you expose those more major, aggressive, and sometimes crazy expensive therapies to? Because ultimately, a lot of people don't necessarily need them, but those are situations where repair might be able to occur. The problem is that damage that's been there for more than a year or two is really hard to reverse, and that's why, again, we talked earlier about trying to be aggressive up front to prevent damage. We're much better at preventing damage. The brain is not a very good it's a pretty good compensator, but it's not a very good healer. So once there's been damage that's set in for a year or two, I mean, multiple sclerosis means multiple scars, and scars are hard. You got to get new wires and new insulation. You can't take the old scars and just put new insulation around them. You need new nerves. You need new wires.
So what I'm taking away from what you're saying is that early treatment is really key for managing this disease. And we have several people joining us with questions today, people who aren't quite diagnosed yet or who have had one attack and so might meet criteria for clinically isolated syndrome. Sandra's writing in and says she's not been diagnosed yet. She actually is meeting with a provider later this month, but she wants to know what happens if you don't see lesions on an MRI, but the person still has symptoms.
So, MRIs have gotten so good that if you literally can't see a lesion on the MRI brain or MRI spinal cord, you may need to do both depending on where the symptoms are, it is hard to make a diagnosis. But at least in those situations, you have to say, well, if you don't see any lesions, and I mean, again, MRIs are not perfect, it's hard to know what the treatment is then expected to do. And I do feel like with clinically isolated syndrome, people who've had their first definite attack of optic neuritis, which is vision loss, or of a spinal cord episode of leg weakness or numbness or bowel or bladder symptoms, or some other first event, they're in the game. I mean, they've had their first attack, and depending on if their MRI shows other lesions, if their spinal fluid shows certain abnormalities, the bands, oligochondral bands, then there's a higher risk that is going to be MS. And in some situations, if the MRI already shows some variably aged lesions, you can already say it's MS. But even with the first attack nowadays, we are more able to either make a definite diagnosis and recommend treatment, or a high-level prognosis or high-level likelihood, and again recommend treatment, because again, you don't want to sit on that and wait for the next attack, the next lesion, the disease progression, which then becomes that much harder to get ahead of, and you're going to be playing catch up more. So on average, we do try and get as early as we can some sense that this is MS or high likely MS, and to be on something. It would be nice to have better things at that point as well to give us a prognosis, because it would be nice to know who we need to be aggressive with therapies, with some of the newer, more aggressive therapies, which also then suppress the immune system more, or with the older therapies that might do just as well for a milder case.
We heard from John, and he's in a similar situation, although he has a diagnosis. He's been diagnosed with transverse myelitis. I want to get you to explain to us what that is, but he's saying disease-modifying therapies aren't an option for him. And we hear from a lot of people who are just trying to manage their symptoms of MS in addition to taking a disease-modifying therapy. So John is asking, since he can't be on a disease-modifying therapy, are there things he could be doing for his symptoms that are very similar to MS symptoms? He has the banding sensation around his torso, the burning type pain, fatigue, and that brain fog that we hear people describe. So I'll quickly ask you, what is transverse myelitis and how does it relate to MS? And then what can be done for those symptoms that he has?
So transverse myelitis can be a diagnosis of itself. It can be a one and done. It can be singular, it's singular sclerosis, not multiple sclerosis, and it happens to involve the spinal cord. Any episode of transverse myelitis could be the beginning of MS, or again, it could be a one and done. So part of the challenge when somebody has a transverse myelitis, or they can have a recurrence of the same level transverse myelitis, and that again gets a bit trickier because then you have a couple different time points, but if it's the same level, again, there are various experts or people who would feel like that's MS, or it's still not for sure, but it's a single event. It's the first event, singular sclerosis. And then we have to say what other factors for or against that going on to be MS might there be. And so if the MRI of the brain is normal and the spinal fluid is normal in the setting of a definite first event in the spinal cord, transverse myelitis, then that would be less likely to be MS. And so on average, that would be a situation that we don't tend to treat. If in that situation there's that first event, that singular sclerosis, spinal cord, transverse myelitis, where there's at least two other lesions in the brain, or there's bands in the spinal fluid, then that doesn't give, it could give a definite diagnosis if the lesions in the brain are different enhancing qualities, or if there's not, but at least it increases the risk that that transverse myelitis is going to go on to be MS. And then we do have to recommend treatment. So, but either way, when you get transverse myelitis as an entity unto itself, as a one and done, or when you get other things then to go on to be MS, you still need to then treat the symptoms. And the same kind of treatments we use to treat the transverse myelitis in MS would be the same treatments we used for the symptoms left over from the transverse myelitis it's an entity unto itself. And so you have to treat the spasticity, the bowel and bladder symptoms, the MS hug situation. The brain fog is a little confusing to me in a sense because ultimately the transverse myelitis affects the spinal cord. If there's not active inflammation that would spill over into the brain, it's not quite clear if the brain is normal in terms of MRI. That would indicate at least some potential hidden lesion or something there, but it would be less likely to be directly related to the transverse myelitis.
Well, thank you for that. I'm going to shift gears a little bit. You talked about vitamin D and the importance for people who live with MS to be taking vitamin D, and you talked about it being a risk factor, or low vitamin D being one of the risk factors for developing MS. So Mike is writing in to ask, should we be telling or having our children take vitamin D, possibly to prevent them from getting MS? I'm sure you get that question from your patients. What advice do you give?
There's no data in that regard. I mean, I think, drink their milk. I guess milk has got vitamin D, and I don't know that there's any reason to be specifically giving them vitamin D supplement at that point, a multivitamin a day, Flintstones vitamin, whatever. But I don't think there's any reason to start checking levels on them, chasing levels on a child or a person with MS.
We heard from Natalie. Natalie says she was diagnosed 4 years ago at age 66. She's had symptoms, since 1975. So a long time with symptoms, but not officially diagnosed until age 66. And she was told she's too old to be on a DMT. I know we talked about stopping DMTs. Alan had a question about that, but I received a few additional questions, so I wanted to ask it again. What can you tell us about DMTs in the older population, and should people be starting or should they be stopping as they age?
So one size clearly does not fit all, and the older population, I guess, could present a variety of issues. We talked about stopping after years of being on them, and in general, on average, I've already said that that's not a good idea, although we may get some data at some point to say, well, because of A or B or C or X or Y or Z, there's a reason to predict that this person could get away at some point in an older age without being on drug anymore. MS is the result of an overactive immune system, and as we age, our immune systems get older and don't tend to be as hyperactive. So it's less common to develop MS in older years, and over the years, people with MS, their immune system tends to be less inflammatory, and there tends to be less discrete new attacks or less new discrete inflammatory lesions. So those are good things. Now, having said that, of course, I mean, there are going to be people with a new diagnosis, relatively older, who have an active onset case. And then we have to put them, I think then it is appropriate to put them on a therapy. And again, depending on their other tolerance or other comorbidities, because older individuals tend to have more other diseases and things, it may impact on which drug that they would go on. the specific example you gave is interesting as well, because again, if somebody literally has had symptoms since 1975, that would be 30 or 40 years of symptoms, and took that long to make a diagnosis. The point being, it must have been a very mild situation. And so, and again, I don't know the exact details and can't know the exact details, but ultimately at that point, it may be appropriate to say, well, geez, yeah, you're definitely diagnosed now. And depending on if you're barely enough to make a diagnosis, you've had a 35-year good run without being on a therapy. What's a therapy going to do now for the next 35 years, which obviously is not going to have another 35 years. So the point being, what comparing the 35 years or whatever we're looking at the math there, would have been like in the past, is there a reason moving forward now for the next 35 years to do something? And the answer at that point could be potentially no, that it's going to be hard to do any better than the last 35 years by being on something for the next 35.
Well, that's very helpful. We also heard from Beth, who is aging, and she says she's had an MS diagnosis for 33 years, and she's starting to go into menopause. And she's wondering what changes, if any, she might expect from menopause. So maybe if I could ask you both ways, does MS affect menopause, and vice versa, does menopause affect MS?
I mean, short answer is no. There really isn't a huge hormonal difference before and after menopause. I think you do worry a little more about, again, some of the comorbidities regards to bone density loss and need for vitamin D, need for calcium, that kind of stuff. But ultimately, and hormone replacement, I think, may or may not be more appropriate. I think that's controversial in general anyway, but the balance may tip a bit more towards doing it because people with MS may have a bit more tendency for bone loss, with, again, partly because of if they're not able to be as active or with their disability, it may again be appropriate to do hormonal supplementation and calcium, vitamin D. But overall, it doesn't seem like MS does anything good or bad at the time of menopause. Yeah.
So a little bit towards the other end of that spectrum, Carrie writes in and says she was recently diagnosed, and she and her husband were about to start a family. And her neurologist wants her to wait for about 2 years to be stable on a disease-modifying therapy before she is to become pregnant. And she's devastated by that news, she says, and she wants to know if that's really necessary. Talk to us about the conversations you have with your patients that are in this situation. What advice would you give to a patient of yours in this situation?
Again, this is where one size certainly does not fit all. I mean, if a young woman that wants to get pregnant has come in with, unfortunately, an aggressive or active onset of MS, I think that kind of advice might be appropriate to try and get them on something to settle things down for a year or two, and then figure out where to go next. But to put the lid on things. If, on the other hand, it's just a new diagnosis and they've already recovered from a mild situation and moving forward, I mean, the problem becomes it may be fully appropriate to go on and try and get pregnant sooner and just go for it. The problem being that if you start an immunotherapy, most of the immunotherapies, conservatively speaking, we want to stop them, injectables or pills or infusions, depending on the infusion, 1 or 2 cycles before trying to conceive. Aubagio is the one that has a little more potential for pregnancy issues, although the data are not totally convincing in that regard. But the point being that in general, you want to stop these drugs before you get pregnant. So if it's been a mild situation, it seems to me like that would not be a bad time to just go ahead and get pregnant. If you start a drug, you're going to need to stop it a couple cycles before trying to conceive. So if you've been in a more active situation, then you'd go on a drug for a while to quiet things down. Once you're pregnant, MS tends to do better on average, especially in the 3rd trimester. There tends to be less disease activity during pregnancy, and there's hormones in pregnancy that seem to be suppressing of the overactive immune system. Estriol may be the one, and there's actually studies going on of estriol as a treatment for MS, and I don't think it's ever again going to be the final answer to MS, but it may be one of those adjunctive supplemental things that might be helpful. But during pregnancy, like I say, MS tends to settle down on average. Not that it's a guarantee, and there certainly are women that have attacks during pregnancy. But I think the one I would say that advice probably would be sound would be if there is an early active onset, and it might just make sense to settle for a while before you get pregnant. So.
Very helpful information. Thank you. So John is writing in. He heard you talking about exercise having positive benefits for MS, and he's trying to leverage exercising and balancing the fatigue that he experiences. And he
He says it's so hard. He put the emphasis on so, not me. And he said, can you make any recommendations to help with his fatigue or how to fight through that to make sure he's getting that exercise?
No, and I think the point is well taken, that I mean, it's easier for me to say, moderate exercise is great, but what is moderate exercise? And you don't want to use up your energy with that exercise. You want it to leverage the exercise. And so, I think, a common phenomenon in MS is overheating, including when you're exercising, can increase symptoms, and not doesn't cause new damage typically. But the point then being, if you're going to try and exercise, do it in air conditioning. If you're outside or something like that, do it in a cool time of the day. Pick your time, pace yourself. Swimming, if you like swimming or can swim, or have a pool or whatever, it's good because it's hard to overheat in a pool as long as it's not a warm pool. But again, I think the point being that, and again, it's easier said than done sometimes, where the balance between exercise augmenting your energy or being your energy, I think is a difficult balance.
So Jamal wrote in and said that his doctor told him he needed to get blood work done routinely because his disease-modifying therapy can lower his white blood cells. He wants to know why that happens and what, if any, effect that would have on him if his white blood cell count did become lower.
So again, depending on the drug, many of the drugs that we use in MS do involve some level of monitoring of blood counts, some monitoring of liver functions in particular. Those are the two major things, I think, that are routinely monitored, and again, at variable frequencies depending on the one. And the white cells, for example, would be a marker for the overall, if the drug is affecting the immune system. White cells are the cells that do damage in MS. So we want to decrease the negative effects of them in some situations. Not that any of these drugs do we monitor them at the level where we're looking to knock down the white count. Some of them do that, but we don't need to have it necessarily to a certain amount to think the drug is working. But just they are definitely then a reflection of the idea that we're decreasing the immune response, or the lymphocytes in as one subset of white blood cells can be lowered by some of the drugs as well, and again are then worthy of monitoring. And sometimes we want to make sure they don't, in some situations we don't want them to go too low, because then that can make a person susceptible to other infections or lingering infections or whatever. And so then that's the reason to monitor them in particular.
So we have a question from Michelle, and I told you each week we have lots of questions about symptom management, and this one's about pain management. She's asking for your thoughts on using cannabis to manage pain.
So, and again, I think there's been at least some data that some of the various THC cannabis extracts, a couple of which are now FDA approved, some are available in some states, some are available in other countries, are beneficial. I worry about medical marijuana per se causing all the other negative effects of marijuana, smoking an unfiltered cigarette, in a sense. But on the other hand, I think that, again, there are some of the extracts that are proven to be somewhat helpful, and can be one of the drugs that are potentially part of the armamentarium. Typically, insurance companies in our state, Indiana, have not paid for them readily, and so people get a sticker shock when they want to try it, and it's going to be an expensive trial. Because ultimately it's nice sometimes to be able to try certain things, and if it doesn't work, well, then at least you've tried it, and it hasn't become the forbidden fruit, Otherwise, if you try it and it works, well, then you have ammunition to try and stay with it.
So I think John will let me have time for one more question, and we have a question from Phyllis. She's asking if there's anything to help with walking problems other than the drug Ampura.
So, again, I think Ampura is certainly a nice adjunctive therapy, but I think even before Ampura, when there's walking difficulties, the first step is to go to physical therapy, have them work with your gait, your balance, see if you need a certain gait assist device, and then also as part of your neurologic evaluations to know what the components of your difficulties are. The physical therapist will work on that, but the neurologist also can try and help optimize if there's numbness that can affect knowing where your feet are, if there's spasticity or tightness or cramping that can affect your walking, if there's other cerebellar things that are going on, and some of those again are treatable, or otherwise physical therapy can help to compensate. But I think those are all things that should be done either before you even get to the Ampura or as part of the Ampura. But certainly that just pushing a pill on the situation is not enough in general.
Thank you so much. That was very helpful. John, I'll turn things over to you to close us out today. think your microphone might be
There
muted,
we
John.
go. That's a little better. Thank you, Julie. And thanks to all of you who submitted your questions. And thank you once again, Dr. Matson, for joining us today. I think one of the best things that anyone can do for themselves, especially during these uncertain times, is to make sure that the information they're getting is credible and reliable. So we'd like to share some resources with you. And these are resources that you can count on to be current and credible. I want to remind you that if we were unable to get to your questions today, the National MS Society's MS Navigator team is your best partner in answering your questions and connecting you to the very best information and resources. You can contact an MS Navigator by phone, email, or through the MS Society's website. I'd also like to acknowledge that we're in the midst of an emotionally difficult time for so many people. And I want to make sure that you're aware that the National Suicide Prevention Lifeline is available 24 hours a day, 7 days a week. They offer free and confidential support for people in distress, as well as suicide prevention and crisis resources for you or your loved one. You can reach them by calling 1-800-273-TALK. That's 273-8255. And if you'd like to continue following Dr. Matson, please visit www.medicine.iu.edu. Every week on the Real Talk MS podcast, I continue the conversation that we start here. So I hope you'll take a few minutes and give Real Talk MS a listen. You'll find the Real Talk MS podcast at realtalkms.com, Apple Podcasts, Google Podcasts, Spotify, Amazon Music, or wherever you find your favorite podcasts. With vital funding from supporters like you, the National MS Society will work to ensure that resources and programs like today's are available and that the MS research community rebounds quickly from COVID-19 so the progress and momentum toward finding a cure continues. As you're able, please make a donation to the Society's COVID-19 Response Fund by texting the word GIVE to 68686, and you'll get a link right to the MS Society's COVID-19 Response Fund webpage. I hope you'll consider contributing today. You can connect with the National MS Society on Facebook, Instagram, Twitter, YouTube, and LinkedIn. And please make sure that you're on the Society's mailing list so you'll continue to receive the latest information on MS and updates on upcoming programs like this one. I'd like to thank Dr. David Matson for joining us today, and I'd like to thank everyone who's joined us for your great questions. Please remember that a recording of this webinar is going to be available on the Society's website at nationalmssociety.org/MSexpert. And now I have a favor to ask each of you. Getting your feedback on today's webinar is really important. So you'll see a survey pop up in a moment when we close out the webinar. And if you're watching on Facebook Live, you'll see a link to that survey pinned to the comments section. And on YouTube, you'll find that link in the program description. Completing the survey makes a real difference. The information you provide helps us continuously improve, and it helps us shape future programs. The survey takes just 1 minute, so I hope you'll take a minute to fill it out. Thanks again to Bristol Myers Squibb and Janssen Neuroscience for their sponsorship support, making programs like this one possible for the entire MS community. On behalf of Dr. David Matson and the National MS Society, I want to thank you once again for joining us. Please stay safe and make healthy choices.